This past week, when I've been on call in the hospital, we were faced with some end-of-life discussions with patient families. These are challenging situations and emotional and not very easy conversations to have. My approach, and I don't know if it's necessarily the right approach, but it has been the approach I have used, is I like to be straightforward with what I'm thinking. If I don't think the patient's going to survive, I'm going to tell the family I don't think the patient will survive. I don't want to hide any of my own clinical judgments from the patient families, because I think they deserve to know, even if it's hard to say. I like to also think in terms of not just extending life, but what does the quality of that life look like? In some instances, we are able to save a life, but we aren't always able to restore a quality of life, and specifically a life with a measure of independence. I had an interesting scenario in the midst of all of this, meeting with the husband of a patient that we saw 4 or 5 years ago. His wife had suffered a devastating aneurysm rupture, and we had debated, should we withdraw support or continue maximum care? In her situation, she was treated and ended up in a vegetative state for 2 years. He was the primary caregiver for his wife, and then she succumbed eventually to pneumonia. Now, even looking back on it with that information, it's not completely clear what the right decision would have been, because he may tell you that that was a sacred experience for him to care for his wife, and he was an unbelievably caring and loving husband. However, I do think it's important to recognize when our treatments of a potentially devastating problem are unlikely to restore quality of life, independence, the ability to think and to communicate normally. Sometimes there really isn't, or a very, very, very low chance that surgical intervention will save a life. And the question comes up, should we operate on that slim margin that there's a possibility that somebody will survive? And I think what patient families are really afraid of is that they didn't do everything possible, that they made that difficult decision to let their loved one go when they knew that there was an opportunity maybe to go in and do surgery and remove a blood clot, and there was some miraculous chance that the patient would survive. In that situation, I think we just have to maintain some degree of realistic expectations. If a patient has very little or no brainstem function, there's just such a small chance that going in and removing a big blood clot is going to make a difference. There are some situations where the patient's families may blame themselves. Should they have taken their loved one to the hospital sooner? Could they have done something differently to reverse the situation? In that situation, I would hope that patient families would realize that not all of these situations can be prevented. One young woman had a problem with alcoholism, and her liver function was very poor, and she was falling over and over. And she ended up having a really devastating subdural hematoma. I don't think in that situation anything could have prevented her from succumbing to that disease. And really, the patient's family had done everything they could to try to help their daughter. And unfortunately, she was unable to quit drinking and to get her health back, and this was the end result. Again, these situations are difficult. My approach has been to try to be as understanding as possible, but also realistic about, are we able to do something to save a life? And if we did something to save a life, what is the likely quality of life that that patient's going to experience? Communicate that to the patient's families, and then try to carry out what the patient families understand to be the wishes and the desires of the patient.